Okay. So the talk basically that I'm going to give summarizes a paper in the New England Journal of Medicine. And I'm essentially going to summarize this talk with 5 slides. Okay. And it's like most talks, you started out with an introduction, overview, and you tell everyone what it is they're going to learn from it. You go through it, and then at the end, you tell everybody what they learned from it again. Okay. And it's based on this paper. In fact, I thought there were more slides, but I guess there's only 5. Okay, so this trial was done, I think about, what's the date on it? It's 15, right? So it was done probably from 2007 through 15. It's a very large trial. It was quite expensive. And the title of the paper is Outcomes of Anatomical versus Functional Testing for Coronary Artery Disease. Anatomical testing is if you look at the vessel with a really nice high-resolution picture and you characterize the lesions in that vessel, right? And you decide, okay, this vessel's really sick. It's got these narrowings, and I'm going to characterize it as severe or mild or whatever. Versus take the person to a nuclear medicine scanner and do a perfusion scan, a stress test. Okay, so that is called functional testing. That, that's the name that was evolved over the years. And it was thought, it was essentially dogma that you should treat ischemia. Okay, if there isn't ischemia there, there's perhaps nothing to treat. If there is ischemia, then obviously this patient needs some kind of intervention. It makes sense. And because it makes sense, everybody believed that's the case, right? That's what. And so when cardiac CT came along, it kind of challenged the dogma, and it was we were able, or are still able, to make these fantastic images of coronary artery disease, right? So the question is, if you put half the patients through that pathway, they just started with that scan, and half of the patients through the functional test, which is normal, what would be the difference in outcomes, right? Would it make a difference, okay? And so the primary question, are there fewer major adverse events? We're going to define that, right? In patients who undergo the CTA, the coronary CTA, versus SPECT. It's mostly SPECT in this thing, which is traditional stress testing. We say traditional because 10 million of these are done a year. So this is what happens, right? So at all of the end of this, we're going to find out that for this group of patients, and there were 10,000 people in the study, it's not a small study, right? The number of major adverse events who underwent cardiac CTA versus traditional stress tests was the same. Okay, in both arms of this trial, whether they went through the CT arm or the nuclear medicine arm, the number of events at the end were the same. And we'll see what a major adverse event is. The other takeaway from this, and it surprised even all of the authors, when they designed the trial in probably 2005, they were expecting with 10,000 people, they would have a certain number of events, right, to do their statistics at the end. They got about 1/3 of the events. So it's a different world. The other result, and we'll see this, and this wasn't really a conclusion that they put in the paper, but when you look at the data, you'll see it's a conclusion, is that we're going to see that CTA reveals coronary artery disease with much greater accuracy than the nuclear medicine. That's going to be obvious from the data. Okay, so how is this trial organized? Schleiser, there we go. Let's put it here. 10,000 patients, so this is not a cheap study. This was an NIH grant, and they spent many millions of dollars figuring this question out. About 50% women, importantly, the patients that were included in this study were symptomatic. And so that means they had some chest pain. If they had a STEMI, remember we looked at imaging with ECG and the change in the coronary or in the ECG indicating that you're having an active heart attack. That's not these patients. Those patients didn't pause to go through this study. They just went straight to the cath lab, okay? So we're on the scale of severity of disease, we're below that group, and we're into the group that have symptoms. They didn't just walk in and say, you know, I'm kind of interested to know what's going on in my heart. No, they showed up at the hospital with symptoms. Okay, so they're a higher risk group than just the average Joe walking around. And they tried to use these clinical indicators to get the mean risk for cardiovascular events over the next 10 years to about 50%. So they're fairly high probability, they're risky people. Huge number of sites, right? 193 sites. So this is what you would call a real world test. Hard to control the quality over 193 sites, but you can answer a question like, if everybody did this, how would it go, right? So it's, you know, just the management of 193 sites is pretty tricky, right? Because each site read their own cases. Some sites better than others, right? So the group was divided into two. 5,000 went to immediately, without question, just went to a CT scan. They got a CT, an injection of a contrast agent, and then a single image of their heart looking at the vessels, right? 5,000, most of whom went to SPECT. Some went to stress echo, which we'll see when we do ultrasound. So here are the primary endpoints of the study: death, myocardial infarction. So they have a subsequent heart attack leading to myocardial infarction. They wind up back at the hospital with unstable angina, which means it's, you know, coming and going like a classic heart attack, right? Or they have a major procedural complication. That means, say, you're putting a stent in and you perforate their artery or something, right? So putting a stent in isn't totally risk-free. And then they followed this whole group for only 25 months, which is kind of too bad. I mean, you spend all this money, I think they should have tried to follow up for longer, but anyway, 25 months. And the interesting thing is, in the group that went to the CTA, that 5,000 people, they had 164 of one of these types of events. When you added them all up, only 164 people had events. Over here, 151 people had events. Therein lies one of the problems with the study, was that these numbers are really low. And they all thought, they're all smart people, been doing this a long time, that they were going to get 3 times that number of events, right? And the reason they had so few events, more than likely, is because the classic historical data was before everybody started going on statins, like heavy dose statin therapy and blood pressure reducing drugs, and just optimal medical therapy became really good, okay? And so that's the good news for everyone, is that, either way you go, as long as you take your drugs and you're on a good drug regime, your probability goes down pretty low of having one of these events. But here's the really interesting data for imaging geeks, okay? So here's the patient flow into the study. And so I reconstructed this, and you're welcome to do this on your presentation, is take what they have in the paper and make it into a diagram that is more easily understood than all of the garbage in the paper, okay? So all of these numbers are real, okay? And the boxes are sized appropriately, okay? So close to 5,000 go into CTA, close to 5,000 go into nuclear stress test. 4,286 were said to be normal after that. 4,000 were said to be normal over here. When you're abnormal over here, you go into the cath lab. So that means they put the catheter in, they inject dye and look at it on X-ray. That's the sort of gold standard of whether or not you have coronary disease. And over here, 406 people were positive enough to send them to the cath lab. Okay, so right off the bat, this group and this group look kind of different when you're sending people to the cath lab, right? We've got 200 more people going to the cath lab on this side, right? So we uncovered disease with higher rates, higher sensitivity on this side, the CT did. I have 3 friends who wound up, not in this trial, but wound up in this box because they did a stress test with this and were found to be normal. And they were anything but normal, right? They went down the road. One of them had a pretty severe heart attack. The other one had 3 stents put in because when they did a cath, he just had ridiculous disease, right? So human beings and your physiology is pretty good at getting around this test, right? Partly because you don't know if the whole thing's depressed. If you have like low flow everywhere, it doesn't show up on this thing very well, right? So anyway, but let's look at what happened to this 406 people, positive enough to get referred to the cath lab. They go to the cath lab, they inject the dye, and they look. 213 out of the 406 were just normal. Well, that's crazy, right? That's half of them. It's more than half of them are normal, right? 193 on cath were abnormal. So this is the group that you're interested in. The cardiologist standing there looking at the cath says, "Oh yeah, you've got significant disease." 193 out of this entire group. Over here, 439 were found to be abnormal on cath. So just look at the difference between this and this. You've extracted 439 abnormal people from this population. Over here, you extracted 193. Right? 170 were found to be normal. And this is where imaging engineers come in, right? You say, well, we got to eliminate that. Like, how do we eliminate this, right? This false positive rate. So it's good. You can focus now your methodology to say, oh, we got to get rid of these false positives. How are we going to do that? Such that your positive predictive value becomes better, right? So what happened here is of these 439 people, 236 got stents, 75 went to get coronary bypass surgery or CABG, right? Of these 193, 120 got stents and 38 got CABG. So twice as many people were treated here as here. Right? So that to me is a significant difference between those 2 pathways, right? But let me ask you a question. Who does this benefit? Right? So if I'm a cardiology department, right, and I do procedures for a living, right? I put in stents for a living, and I do CABG for a living. When I look at this pathway, no, it's pretty good compared to this. So I get twice as many referrals on this side. Right? If I'm an insurance company, so now I'm United Health or someone like that, and I look at these 2 pathways, this study, which one looks better to me? Well, I'm the insurance company. Well, this one, I do a lot less stuff, right? So I do this test, and then a bunch of people wind up here, and then I only have to do this many procedures down the line. So this looks better to me as an insurance company, or as Medicare for that matter, right? So I think the issue is that when you have this group and they have to come up with a statement, right, based on this trial, the very interesting statement that they come up with is these 2 pathways are identical. That was a statement at the end of the paper. I'm like, well, are they? You know, The reason is that there was only 164 events here and 151 here, right? We only treated 236 and 120 and 75 and 38. So how are you going to generate a difference in the rates of events on these two sides when you're treating so few people, right? Very, very difficult to come up with a significant difference between these two pathways when the numbers get really small, right? Not only that, your homework this week, you'll see that you have a paper that is the COURAGE trial. And it shows that whether or not you get PCI, right? If you're on the right drug regimen, it just doesn't matter if you get PCI. So the only thing different between these two branches is that we have a few more PCIs, but that's a completely insensitive thing. If all of these patients are on the right drug regimen, then there's going to be no difference, because there's no difference if you give them PCI or zero PCI, right? So when they looked over, 24 months and, what the hazard was of the functional testing group and Anderson, they were absolutely identical, right? And so that's why, but you can see the number of patients that were followed significantly dropped off after about 36 months. But that's why the conclusion of this trial was these two pathways are identical. And however, I'm not sure I believe that. I think that this number is a big number. And I've been doing imaging a long time, right? And when you do two imaging modalities and one gives you 193 out of your 5,000, one gives you 439, that's different, right? That they're uncovering different things. These are a factor of two difference, but there's no way we're going to detect a difference in events given that small number of people treated. You would need like 10,000 versus 5,000 or something. And we've even shown when you look at COURAGE, if all of these people get PCI and none of these, there won't be much of a difference in events, right? So really the power of this trial, I think, is this number here. And there are other subsequent analyses of these things. There's another paper called the ischemia trial, if somebody wants to do that, which is fascinating, in which they only looked at patients who had essentially that verified ischemia and then decided to put stents or no stents in those patients, right? And there still wasn't a difference, so. Okay, so that's like a 15-minute shot on that. Yeah, question?
The statements represent like a false negative, or they don't prove that they were looking.
So, well, so your question is, can events occur from the people that wound up in the green box?
Yeah.
Right, yeah.
Yeah. Oh, but that's not entirely where the events are from.
No, they're from the whole group.
So it's not strictly.
Right. Okay, yeah.
Could I have any said a few years ago about seeing images like a really blocked artery, the person who gets this thing put in, the person who doesn't sometimes.
Yeah, we touched on this a few lectures ago when we were looking at the X-ray images of the really blocked artery and then what it looked like with a stent in it. And the question is like, is like, how does this relate to opening that artery? And the issue with that one was, remember, this study eliminated all of the people that had obvious ongoing heart attack happening, like with an EKG abnormality and stuff like that. There is no question. So now let's go back and restate it now that you've got it in context. For those patients, there's absolutely no question you should put a stent in. You will save their life a lot of the time, right? Because they have this active heart attack going on. These patients in this PROMISE trial were stable patients. They didn't have an ongoing heart attack, but they did have chest pain. So they had symptoms, right? And in many trials, it really matters to understand absolutely what the group is coming into the trial, right? Because you can. Okay, great. Thanks, guys. it.